everyone. Happy evening, a very good evening. I hope and I believe all of you are doing well. A quick note, everyone. Am I audible and visible? Yes. Okay, that's great, guys. So I hope all of you have attempted the radiology test that we had. It had 50 questions, all very high yield questions, right? Like these are the must know questions. And I hope all of you fared well in the test. So we are going to discuss questions of the test that we had. If you have any queries, please drop it in the live chat, so that we can address that. And we'll start discussing the questions here. So the first question that we had, a similar question was asked in the recent INI-CET exam as well. This is a question that has been asked in one of the previous NEET PG exams as well. Right. So what do you think is the diagnosis in this case? Drooping of the eyelid, constricted pupil, lack of sweating. So there is ptosis, meiosis, enhydrosis. So all of these are pointing, the features are of Horner syndrome, right? What is this? This is Horner syndrome. So there is also weakness, pain and numbness in the right arm. So the upper limb features are also there, right? So and apart from that, it is given that there is an apical lung mass on the right side. So what is the imaging modality of choice? So now based on this, putting all the dots, connecting all the dots together, now we can say that the diagnosis here, this apical mass which is mentioned here, this is a Pancoast tumor, right? The apical tumor, the superior sulcus tumor, Pancoast tumor, which occurs at the lung apex, close to the lung apex. If this is the lung apex, right, close to the lung apex, we have the brachial plexus, the sympathetic trunk which is present, and that is why the invasion of that is leading to these symptoms in Pancoast syndrome, classical one, right? So what is the imaging modality of choice for Pancoast? It's going to be MRI, because particularly we have to look at the brachial plexus invasion as well, and that is best seen on MRI. The soft tissues, the nerves are best seen on MRI. Now the INI-CET exam question was, what is the best to confirm the diagnosis? So in that case, remember, in any lung mass, it is CT guided biopsy that we do, which is the gold standard to confirm the diagnosis in case of a lung mass, right? So we do CT guided biopsy. If we want to see the brachial plexus invasion, then we will go for MRI, right? If we want to confirm the diagnosis, then we will go for CT guided biopsy. Is this clear with everyone? Yes. Will the biopsy, can the biopsy cause pneumothorax? Absolutely yes, right? One of the complications that can occur with biopsy is pneumothorax, especially if we go into the pleura or the fissure where there is a pleural space, and that is why we have to be very careful, and that is why we say CT guided biopsy and not a blind biopsy that we do there, right? So it definitely requires expertise. Okay. All right, so I hope this is done, and this is the image showing the apex tumor, right? This is a image showing the mass in the apex, and it can invade into the brachial plexus. This is going to be Pancoast tumor. Okay, this is going to be Pancoast tumor. Going to the next one. What is this? CT scan, identify the structure. Right, so look at the CD. This has been asked twice in the FMGE exam, identifying the chambers of the heart. Easiest way to identify the chamber which is marked here. Is it the anterior most chamber or is it the posterior most chamber? What chamber do you think is this? Yes, is it the anterior most or the posterior most chamber? Very good. This is the posterior most chamber that you are seeing because it is close to the vertebra, and we have discussed in our videos that the posterior most chamber of the heart is the left atrium. The anterior most chamber is going to be the right ventricle, opposite of left atrium. So this is the left atrium that you are seeing here. And suppose if I ask you the question, what is this structure? What is this structure related to the left atrium? What do you think is this? So these structures, you can see they are draining into the left atrium. So what drains into the left atrium is the pulmonary vein, not the pulmonary artery. So that's going to be the pulmonary vein. And what is the structure marked B here? Structure marked B is the descending aorta, right? That is the descending aorta in the posterior mediastinum close to the vertebra. So this is going to be right ventricle, this is left ventricle, this is left atrium, and this is going to be right atrium. Is this clear with everyone? The four chambers of the heart, very, very important. Coming from the left ventricle, this is going to be the aorta, right? The aortic root is what you are seeing there. That's not the arch of aorta. Please remember, this is descending aorta. Arch of aorta, you see as if this is the trachea, adjacent to that, like a arch, like a inverted C shape, that is going to be arch of aorta. Okay, that's going to be arch of aorta. Okay, clear with everyone? Right, so the correct answer here, this is going to be left atrium. Going to the next one, what is the mark structure here? Is it concha bullosa, agar nasi, pneumatized superior turbinate, or is it the Heller cell? What is it? Okay, some of you say A, concha bullosa. No, understand the term, what is concha and what is bullosa? What is concha bullosa? Yes. See, concha means the turbinate. Bullosa matlab, right, like in the lung also you have bulla, something which is expanded. Okay, so concha which is expanded, middle turbinate which is expanded with air, that is going to be concha bullosa. So concha bullosa is middle turbinate expanded with air. Okay, this one is the orbit infraorbital air cell that you see there. So this is going to be the Heller cell. Heller cell is the infraorbital air cell that you see, that is the Heller cell. Let me show you the other images. Okay, tell me what is this one here? This is one of the previous INI-CET exam question as well. What are you seeing in this image? Is it agar nasi? This is not agar nasi. No. See, this is the inferior turbinate, this is the middle turbinate, and this is the superior turbinate that you are seeing there. So this one which you are seeing here is the pneumatized superior turbinate. Okay, this is the pneumatized superior turbinate. This one here which you are seeing, this air cell, this is the optic nerve coming from the orbit. So related to the optic nerve, ON optic nerve is ON Onodi cell. Okay, that's the Onodi cell. This one which you see here, again this infraorbital one that you are seeing here, this is the Heller cell. Okay, this is the Heller cell, infraorbital. And this is what is agar nasi. This is the frontal sinus draining here. In front of the frontal recess, the air cell which you see, ethmoidal air cell, sabse aage, that is the agar nasi. This is where you see the agar nasi. Okay, this is the agar nasi air cell that you are seeing anterior most. You are not even seeing the complete maxillary sinus yet. It is the anterior most ethmoidal air cell, which is agar nasi, anterior to the frontal recess. Is this clear with everyone? Okay. Right, so this infraorbital one, this is the Heller cell that you are seeing there. Going to next one, what is the imaging study of choice in the setting of head trauma? So a patient who comes with head injury, what imaging study will you prefer doing in that case? Helical CT, spiral CT means the same, right? The terms, helical or spiral means the same. Is it without contrast or with contrast, A or B? It's going to be without IV contrast, right? Why without IV contrast? Because what do I want to see in a patient of head trauma is acute hemorrhage, right? I want to look for whether there is intraparenchymal bleed, EDH, STH, SAH, what kind of bleed is there? What fracture is there? So I want to see acute hemorrhage, I want to see fracture. I can see that on non-contrast CT itself. So that is why we will not give IV contrast, is not needed. Okay, contrast scans are needed when there is any mass, any vascular pathology like thrombosis, aneurysm, right? Any infective inflammatory etiology you are suspecting. In that case, you do contrast scan, right? Otherwise, in a head trauma patient, CT is enough. MRI is the investigation of choice for which particular head injury? MRI is the investigation of choice. For which particular head injury, MRI is the investigation of choice? Correct. Absolutely right. It is diffuse axonal injury. Okay, diffuse axonal injury, where classically they give you a patient with road traffic accident, worsening GCS, but the CT scan can be normal. What sequence of MRI particularly do we do for diffuse axonal injury? What MRI sequence? It is SWI, susceptibility weighted imaging. Okay. In a patient of stroke, the first investigation again is a CT, not MRI, right? The most sensitive is DWI MRI, but first you always do a CT. Going to next one, non-contrast spiral CT is investigation of choice for. What will be the answer to this one? ठीक है, tell me which are the options you rule out the first कि ये तो नहीं होगा. See, logically thinking, pulmonary embolism, mesenteric ischemia, these are like vascular pathologies and the vessels appear white only on contrast enhanced CT. So we have to do contrast scan for vascular pathologies, right? So for acute pulmonary embolism, CT pulmonary angio, that is a contrast CT is what you do, okay? Now for acute prolapse intervertebral disc is a type of cartilage, a soft tissue. It is best seen on MRI. Okay? It is not seen on CT, it is seen on MRI. So it is acute ureteric colic, very, very frequently asked. Acute ureteric colic. So basically you want to see the urinary tract stone which is calcified, and that calcified stone you can see on CT. You can see on non-contrast CT. Okay? So A and D, remember that intervertebral disc. So your just spine, MRI spine is one of the most common MRIs done in the diagnostic centers, the radiology centers, because the backache is so common, right? So for that, we do MRI. Degenerative spine disorders where the disc is getting prolapsed, we do MRI. Okay? I hope now you will remember this कि डिस्क के लिए हमको MRI करना पड़ता है. CT पे डिस्क नहीं दिखेगा. डिस्क is not a bone. Right? And you want to see the nerve compression. Again, nerve is a soft tissue. Disc is a soft tissue that is best seen on MRI. Okay. Next one. Teardrop appearance on PNS X-ray is seen in what fracture? So the teardrop appearance is seen in fracture floor of orbit. Imagine dropping. When the floor is gone, there is a drop happening. We have discussed this in our videos. So you will see something dropping from the floor of the orbit. There is fracture here. The soft tissue from there is dropping down. So this is teardrop is seen in fracture floor of orbit, which is also called as blowout fracture. Okay, which is also called as blowout fracture, right? Next one. A patient with previous history of cardiac surgery, dyspnea, all these things are mentioned here. And there is this image. This is one of the images has been asked in one of your previous FMG exam as well. What are you seeing in this image here? What is the finding that you are seeing in this image? Right? Can you appreciate this white line along the heart border? So that is, what is white on X-ray? White on X-ray is calcification. So this is the pericardial calcification that you are seeing here. Very good. So calcification, C for C, calcification of the pericardium is seen in constrictive pericarditis. Okay? So that is why the answer here is going to be constrictive pericarditis. It is pericardial calcification that you are seeing there. Okay? So for example, look at this image. Okay, first identify this investigation. Is this X-ray? Is this CT? Is this MRI? This particular image that I'm showing you, is this X-ray, CT or MR? Okay, some of you are right. Can you appreciate these white bones, the ribs which are here, the sternum which is there? Look at the cortex. Don't look at the inside of the bone. So this is the CT, and look at how the calcification can be very well appreciated on CT. This is same like X-ray पे जो calcification देख रहा था, वो X-ray CT पे you are seeing this calcification. This is constrictive pericarditis. Okay, this is constrictive pericarditis. Next one. What do you think will be answer to this one? Patient presents with low grade fever, headache, CSF में lymphocytes है और leptomeningeal enhancement है, basal exudates है, leptomeningeal enhancement, basal exudates, fever, lymphocytes. What is this? What is the diagnosis? Very good, right? So basal exudates is a very, very important finding, right, that you see in TB. Along with that, what does this leptomeningeal enhancement suggest? It suggests that there is meningitis. The inflamed meninges are what are getting thickened and they are getting enhanced. So basal exudates, leptomeningeal enhancement, lymphocytosis, fever, all of this is TB. What are the findings that you are seeing in this image? Okay, can someone identify this structure here? What is this structure here? What is this labeled structure here? Yes. What is the label structure? Anatomically tell me that. Posterior horn of third ventricle. Third ventricle का कोई posterior horn नहीं होता. It is a lateral ventricle which has the anterior horn, posterior horn and the inferior horn. No, this is not the chordate. See, it's appearing dark like the fluid in the brain. So this is fluid containing area, guys. Look at the color first. It is dark appearing, like this is appearing dark. The frontal horn, it is appearing dark. So this is CSF containing. This is not any solid structure like thalamus or caudate. Okay? And can you identify this lobe of the brain? What is this lobe of the brain? Tentorium cerebellum क्या है? ये वाला जो lobe होता है, this is the temporal lobe. So this is the temporal horn of the lateral ventricle. Temporal horn is the inferior horn. Okay, it is the inferior horn of the lateral ventricle, not the posterior. Posterior is the occipital. Okay, so look at how prominent these temporal horns of lateral ventricles are, the frontal horns of lateral ventricle. This is the area, third ventricle is prominent. This is the fourth ventricle which is prominent. So the ventricles are prominent here. So basically telling you that this patient also has hydrocephalus. Remember, meningitis is an important cause of hydrocephalus because the CSF is not getting drained, it's not getting absorbed. Apart from that, this is not the subarachnoid hemorrhage. If it would have been a plain CT, then I would have called it a subarachnoid hemorrhage. This is a contrast scan showing that these are the enhancing meninges. Okay? These are the enhancing meninges. This is meningitis. So meningitis with hydrocephalus, this is going to be TB. Okay, this is going to be TB. Is this clear with everyone? Right? Correct. Racing car, correct. That has the posterior horns which are prominent. Colpocephaly that you see in corpus callosum agenesis. Okay, this is TB, meningitis with hydrocephalus. Is this clear with everyone? Great. Next one, 25-year-old patient with a palpable breast mass. So what is the best initial test that you would do here? What is going to be the answer to this one? What will you do? Okay, so confusion between B and C. See, particularly it has been mentioned 25-year-old patient. So that means this is a young female. So in a young female, how is the breast? The breast is dense glandular breast, right? So in a dense glandular breast, does mammography help? No, because the dense breast by itself will appear white. In that, you want to see the white mass, right? So that will become difficult. Right, so that is why we do not do mammography in less than 40 years of age because the breast is dense. Okay, so what do we do in that case is breast ultrasound. Okay, we go for first investigation in that case is going to be ultrasound. Is this clear with everyone? If this would have been a patient with history, family history of breast cancer, a 25-year-old patient with family history of breast cancer, BRCA positive. So it's a high risk female. So in that case, we would have gone for MRI because MRI is the investigation which picks up the ductal carcinoma in situ very well. Okay? No, it's not because it is painful. That's why we do not do mammography in young. Mammography is painful even in like whatever age patient you do because you are compressing the breast there. Because the breast is dense in a young female, you will not be able to appreciate the small white micro calcifications in the white breast, and that is why we do not do. The yield is not very good. So that is why we do not do mammography in young females. Okay, so in that case, it's going to be ultrasound. High risk female, it's going to be MRI. Right. Less than 40 years, we do not do mammography. Which of the following radiation types has a Bragg peak? PYQ. Bragg. Remember Bragg. BR is seen in PR. PR is protons. Okay, it is seen with protons. What is Bragg peak? So when we use proton beam as in radiotherapy, so proton beam, when it goes into the body, it hardly gives any radiation to the superficial tissues. When it reaches the tumor site, it gives all the radiation, right? Like a peak. It is suddenly showing that peak. So remember, it is protons which show the Bragg peak. Is this clear with everyone? Yes? Done? So that is why the advantage with the proton beam is that it gives a pencil beam like targeted therapy. Okay, pencil beam like targeted therapy is what you can achieve with the proton beam. Okay, all right. Going to the next one. 16-year-old male, chest x-ray में there is hypertransradiant hemithorax. So which one will not be your differential diagnosis? What do you think will be answer to this one? Okay, first of all, tell me that what do you mean by hypertransradiant? What do you mean by hypertransradiant hemithorax? Is it a black hemithorax or is it a white hemithorax? Yes? Hyper means more. Transradiant means transmitting radiation more. So is it going to be like air or is it going to be like bone? So decode the term. Hypertransradiant means increased transmission of the radiation. That means there is decreased density, right? And that means it appears black like air. Okay, it is black like air. So the question is basically in which one you will not see a blackout hemithorax. So let's understand the options here. McLeod syndrome, which is also called as Swyer-James syndrome. Okay. So what is this McLeod syndrome or Swyer-James syndrome? It is obliterative bronchiolitis post-infective. It generally follows a post-viral infection and there is obliterative bronchiolitis. That means the bronchioles get inflamed, they get obliterated. So what will you see there is a lot of air trapping. ठीक है, so air बहुत ज्यादा होगा तो black दिखेगा. So this is going to be black. Okay. Poland syndrome. What is Poland syndrome, guys? Poland syndrome. It is congenital absence of pectoralis major muscle. Okay, so think logically. If I take a x-ray, chest x-ray of a patient with Poland syndrome, that side where the pectoralis major is absent, on that side, the chest, the hemithorax will appear more black or more white? Because the pectoralis major is absent, so on that side, how is the chest wall density? There is decreased density. So how will it appear? Again, it will appear black. Remember, wherever the density is less, it appears black. Okay, it appears black. Poliomyelitis, again, there is muscle atrophy. So there is decreased density. So it appears black. So ruling out the options, the first three options are black, black, black. So the answer is going to be pulmonary agenesis. Pulmonary agenesis means like there is no lung, right? So there is no air. So there is no black area there. So pulmonary agenesis will not appear black. Rather, it will appear white because there is no lung, no air, so no black area. So the answer there is going to be pulmonary agenesis. Is this clear with everyone? So this is a very conceptual question. I hope you've understood the concept behind this now. Okay. Right. And what are the three main causes of whiteout hemithorax? What are the three main causes of whiteout hemithorax that you should always remember? We have discussed this in our videos. Three main causes of whiteout hemithorax. So you differentiate them based on the tracheal shift, same side shift, opposite side shift, no shift. Whiteout, right? We are talking about whiteout hemithorax. Quickly. That is consolidation, collapse, and pleural effusion. Okay. consolidation, collapse, and pleural effusion. The three main causes that you should remember. Atelectasis is nothing but collapse. So remember, even that is white. Consolidation, collapse, and pleural effusion. Okay, going to the next one. A child presents with post-traumatic enlarging scalp mass, focal deficit, seizures, and this is the CT shown. So what is the diagnosis? This is also one of the PYQs, has been asked in NEET PG or INI-CET exam. So पोस्ट ट्रॉमा एक enlarging mass है, साथ में ये CT image दिया गया है, where you are seeing that there is this gap in the skull bone, and through that the brain parenchyma is trying to herniate out. So that is the classical history in leptomeningeal cyst, right? So that is a classical history. Trauma के बाद फिर enlarging scalp mass आ रहा है. You are doing CT or MR. You see a gap and the brain trying to herniating out there. So that is leptomeningeal cyst. Is this clear with everyone? Leptomeningeal cyst. This is also called as growing fracture, right? The bone is separating. That is also called as growing fracture. Why not the subdural hemorrhage? It will not cause an enlarging scalp mass, first of all, right? And you are not seeing that classical crescent shaped hemorrhage there. Okay. What is the diagnosis in this case? One of the options in the previous question. This one where you see the subperiosteal hemorrhage with calcification not crossing the midline. This is going to be cephalhematoma. Okay, which is on one side itself, it does not cross the midline. That is cephalhematoma. Okay, cephalhematoma has been asked in exam previously. Next one. Patient with RTA undergoes FAST. So which region is not included in FAST evaluation? Right, so what is going to be the best answer here? The question is on FAST, not on EFAST. Right, so in FAST, pleural cavity is not included. Okay, pleural cavity is included in EFAST, not in FAST. So the answer here is going to be pleural cavity. Right flank view, left flank view, pericardial view, and pelvic view. The four areas that you have in FAST. What is the full form of FAST? Is it fast abdominal sonography for trauma? No, right? Please remember, don't get confused when you are asked full form of FAST. It is focused assessment with sonography in trauma. Okay, it is focused assessment sonography in trauma. It is not fast abdominal, it is focused assessment. Okay. Next one. What are you seeing here? Patient with 4-month history of severe abdominal pain, hyperechoic foci scattered throughout the pancreas on USG. There is irregular contour of the pancreatic duct, duct dilatation. So even if you don't have a look at the image, okay, what do this hyperechoic foci scattered throughout the pancreas represent? What is hyperechoic foci on ultrasound? That is calcification. Pancreatic calcification, C for C, remember it is chronic pancreatitis. Okay, it is chronic pancreatitis. So this is going to be chronic pancreatitis. Look at the CT image here. This is where you are seeing the pancreas. Okay, so let me outline the pancreas here. This is where you are seeing the pancreas, and these white areas, they represent the calcification. Okay, they represent the calcification. Is this clear with everyone? So calcification, chronic pancreatitis. What else do you see in chronic pancreatitis? Dilated pancreatic duct. Okay, dilated pancreatic duct is seen in chronic pancreatitis. Okay. Next one. What are we seeing here? A neonate is brought with a history of unable to swallow saliva. Aspirate on feeding. Feeding tube is inserted. Cannot be passed distally. So what is the diagnosis? So look at the image here. This is the feeding tube, and you can see the feeding tube is coiling upwards. It is not able to go down. The feeding tube is not going down, but it is getting coiled upwards like this. So this is what you are seeing is a coil, right? Coiling of the feeding tube. So this is suggestive that there is a blockage here. So there is esophageal atresia. Okay, there is esophageal atresia. Is this clear with everyone? The tube is not able to go down because there is esophageal atresia. What do you see in hiatus hernia radiologically? What will you see on a chest x-ray in hiatus hernia? Yes, anyone? See, scaphoid abdomen lavish, that's the term we use for congenital diaphragmatic hernia, where all the bowel loops have gone into the chest, so the abdomen has become scaphoid. So that is congenital diaphragmatic hernia. Hiatus hernia, the stomach is coming into the chest. Very good, absolutely right. So shadow behind the heart, classically they will give you a retrocardiac opacity with air fluid level, right? The stomach which is herniating up behind the heart, so retrocardiac, it will have the air and it will have the fluid. So there is going to be retrocardiac opacity with air fluid level. Best for hiatus hernia is not a x-ray, it's a CD scan that will show you the hiatus hernia very well. Okay, right? Okay, let's go to the next one. What is the most probable diagnosis? What collapse is this? Okay, so can someone tell me the sign and what lobe collapse is this? Very good. That's left lower lobe collapse. Absolutely right. But what is the sign that is seen here? Are you seeing anything which is telling you that this is left lower lobe collapse? Can you appreciate that this is the heart that you are seeing, and overlapping this heart, you are seeing like, you know, some dense opacity overlapping the heart. This is not batwing. Okay, can you appreciate some dense opacity overlapping the heart? That is the collapsed left lower lobe. Okay, that is the collapsed left lower lobe. Collapsed lobe appears white. So that is the white that you are seeing there. Okay, yes. And the sign that is mentioned in the left lower lobe collapse, this is called as flat waist sign. Okay, what do you see is flat waist sign. The cardiomediastinal border, it becomes flat, because when the left lobe is collapsing, the heart also tries to shift to the left side, so that curve is gone. So just remember, if at all you are asked this question, flat waist sign is seen in collapse of which lobe? It is left lower lobe collapse. Okay, it is left lower lobe collapse. Right? Clear with everyone? Does anybody know what sign do we see in left upper lobe collapse? Left upper lobe collapse. What will happen in left upper lobe collapse? There's one sign. Let me tell you what that sign is. So surrounding this aortic knuckle, you would see a sickle-shaped air. So you will see a sickle-shaped air surrounding this arch of aorta, aortic knuckle. What is that sign called as? Remember, left upper LU, that is called as Luft-Sichel sign. Okay, so if you are asked where do you see Luft-Sichel sign, it is left upper lobe. Okay, that is the Luft-Sichel sign. Okay, Luft-Sichel sign. Okay. Going to the next one, middle-aged patient with acute abdominal pain. Right, when you are asked question like this, you don't have to break your head on the image. You have to go retrospective. Look at the options. Acute appendicitis hai kya? So I will try to locate the appendix. Where will I try to locate the appendix? In the RIF. Okay. So this is the cecum ascending colon, and this is the appendix here. Okay. Cystitis, you will try to look at this bladder. Cholecystitis, you will try to see here. Okay, gallbladder के area में. Urinary bladder calculus, कुछ white नहीं दिख रहा है. Right. So what are you seeing here is, this is the appendix. Okay, this is the appendix which is appearing prominent, thick-walled, and the fat surrounding that is appearing inflamed. The fat is appearing hazy. That is called as fat stranding. So this is going to be acute appendicitis. Okay, this is going to be acute appendicitis. So whenever you are asked question like this, go from the option to the image and try to rule out the option. So this is going to be acute appendicitis. Is this clear with everyone? What do you see in acute appendicitis? Any organ which is acutely inflamed becomes large in size. So you will see a distended thick-walled appendix. Okay, a dilated appendix, a distended thick-walled appendix. There can be surrounding fat stranding, that is inflammation, and there can be fluid also present. Acute inflammation has fluid also present. Okay. Next one. What is the structure marked here? Are you talking about this whitish area in the left upper area? This is the stomach. This is the liver here. This is the stomach here containing the oral contrast. That is why it is appearing white. This is the portal vein supplying the liver. Okay. Okay, guys. What do you think? This is third ventricle. See, think logically. The first option you rule out is third ventricle. Why? Okay, in the test, the arrow was not present. So let me check that and ask the team to get it rectified. Question number 18. Okay. See, why this is not third ventricle? Because these are the ventricles containing the CSF. This is the CSF. The CSF is appearing white in this MRI. Third ventricle contains CSF. That also should appear white. But the area which is marked here, that is appearing dark. Okay, that is appearing dark. So this is not third ventricle. This is something that you can see is going across the midline. Think logically कि ये जो है ये ऐसे midline cross कर रहा है. What is the structure in the brain which crosses the midline? What is the structure in the brain which crosses the midline? That is corpus callosum. Okay, so this is going to be corpus callosum, which you can see is crossing the midline, and this is the posterior part, this is the anterior part of corpus callosum. Okay, so genu, splenium, anterior is the genu. Okay, so all this black that you are seeing, this is a white matter. On T2 weighted MRI, the white matter appears dark. Okay, on T1 weighted MRI, remember in T1, one for anatomy followed, white matter appears white on T1. In T2, the white matter appears dark. So this is the white matter, which is the splenium of the corpus callosum. Is this clear with everyone? Yes, it has commissural fibers, the connecting fibers. Next one. Hearing loss, tinnitus, contrast enhanced MRI. What is the diagnosis? What sign are you seeing here? What is the classical sign that you are seeing in this image? Appreciate the narrow cone-like area and the bulging part, that is the ice cream cone appearance, right? This is the ice cream cone appearance. Remember, we have remembered it with the trick. Eating ice cream and eating shawarma together. Shawarma and ice cream go together. So remember, vestibular schwannoma, it has the ice cream cone appearance. The narrow part in the meatus and the bulging part outside. So this is vestibular schwannoma. In which condition we have bilateral vestibular schwannoma? Bilateral vestibular schwannoma is hallmark of? Very good. Neurofibromatosis. Which neurofibromatosis? Remember NF2. Bilateral is 2, NF is 2. So NF2 has bilateral vestibular schwannoma. Any patient with bilateral vestibular schwannoma is NF2. Okay, remember that. Next one. Tip of iceberg sign is seen in which ovarian tumor? Tip of iceberg sign. It is ovarian dermoid. Okay, it is ovarian dermoid which shows the tip of iceberg sign. Okay, right. Remember ovarian dermoid, also called as teratoma. It has all the 3 germ layers present. We have spoken about it in our videos. Ovarian dermoid में क्या present होता है radiologically? आप क्या देखते हो? If you are doing CT, what do you look for? Ovarian dermoid, presence of? What do the teratomas contain? They have fat, they have calcification also present. Okay, fat is present, calcification is present. How do you identify calcification on CT? It will appear white. How do you identify fat on CT? It is dark. Why is it dark? Because what is the HU value of fat, anybody? What is the HU value of fat? It has negative HU value. Very, very important to remember, which is minus 50 to minus 100. It appears dark. Negative HU value, it appears dark. Okay. So remember that when you see a mass on CT with fat and calcification, it's an ovarian dermoid because it has calcification as well. So when you try to do ultrasound, what do you see with calcification? It gives posterior acoustic shadowing. So the area behind the calcification appears dark. So that calcification is not allowing the entire depth of the tumor to be visualized. You are just seeing the tip, and that is why it is called as tip of iceberg sign. Okay, tip of iceberg sign. So for example, this is how you see ovarian dermoid on ultrasound. You are just seeing this white curvilinear line. Uske पीछे सब कुछ black दिख रहा है because this is not allowing the sound to go beyond, and that is why we are not able to visualize this area. Okay. The other sign that you see in dermoid is dot and dash appearance. Right. The hair present. There are hair also present in dermoid. So that hair gives the dot and dash pattern. Okay, so that is also important. Is this clear with everyone? Okay. Next one. X-ray is shown. What is the diagnosis? Why do you think? The answer here is Turner's. Why the answer is Turner's? What are you seeing here? Absolutely right. If you look at these metacarpals, look at this fourth metacarpal. So can you appreciate this fourth metacarpal which has become short? So this is the short fourth metacarpal which is seen in Turner syndrome, pseudo-hypoparathyroidism. So the short fourth metacarpal, that is why this is going to be Turner syndrome. Remember, important cause is Turner syndrome, short fourth metacarpal. Okay, next one. What is the diagnosis here? Why not B? That is rickets. See, rickets में it is going to be the weight bearing bones, that is your radius वगैरह जहाँ पे changes आने वाले हैं. ठीक है, you are not seeing any of that here, the cupping, the fraying, the splaying, right? Very good. This is chronic osteomyelitis. Why? So can you appreciate this white area? This white area in the center with the surrounding bone which is appearing very unhealthy, right? Not very clear bone. So that white area in the center, that is called as sequestrum, which is the dead bone which is appearing white. And sequestrum, this is a finding that you see in chronic osteomyelitis. Okay, that you see in chronic osteomyelitis. What is the history in chronic osteomyelitis? The patient comes with discharging sinus. Okay, the patient comes with discharging sinus through which the bone fragments can come out. Okay, so that is the history that you have in chronic osteomyelitis. Sequestrum is the dead bone that you are seeing which appears white. Next one, classical image, right? This is like a spotter image. What is the diagnosis here? Can you appreciate this bone fragment in this lytic lesion? Proximal humerus is a common site. This is a young age patient. This is the fallen leaf sign or the trapdoor sign. You can see the bone fragment falling there. This is simple bone cyst. Okay, not aneurysmal bone cyst. Aneurysm, as the term says, it's going to be more expansile lesion. Okay, it is going to expand the bone. This is a classical simple bone cyst with the fallen leaf sign. Okay, trapdoor sign of fallen leaf sign, very, very important. Next one, what are you seeing here? A term neonate with tachypnea on day 1, hyperexpanded lung fields, prominent vascular markings, prominent interlobar fissure. What is the most probable diagnosis? It's not diaphragmatic hernia because they have not mentioned the bowel loops in the chest. It's not congenital lobar emphysema. Think logically, congenital lobar emphysema will be like emphysema means a lot of air. So black area is what you are going to see in the lung. This is transient tachypnea of the newborn, right? Very important finding. Prominent interlobar fissure. So what happens and why do you see transient tachypnea? Is a term, generally a term baby with history of LSCS. That the vaginal delivery is not there, so the fluid from the lungs is not getting squeezed out. So there is presence of fluid in the fissures, and that is why the fissures appear prominent. There can be fissure in the pleural space as well, so there can be lamellated pleural effusion as well. The prominent fluid in the fissures, right, it can give this sun ray appearance also that is mentioned. Okay, so sun ray appearance, prominent fissure, pleural effusion. All this, when the fluid gets drained off, then the tachypnea, the breathlessness goes off. And that is why this is called as transient. Okay. So remember, this is going to be transient tachypnea of the newborn. Okay. Next one. What sign are you seeing here and what is the diagnosis? This is a barium enema that you can see. यहाँ से barium आ रहा है, barium आ रहा है, and then the barium is becoming like a claw. Absolutely right. So this is the barium which is going like a claw. So this is the claw sign which is seen in intersusception. Remember intersusception, one bowel going inside other. When you do the barium, it forms a claw around the intersusceptum. What is the other barium finding that you see in intersusception? One is the claw sign, and which is the other second sign in barium study in intersusception? Very good. The coiled spring sign. Correct? That is the coiled spring sign in between the intersusceptum and intersuscipiens. You will see the barium going like a coiled spring. So that is coiled spring sign. And what sign do you see on UST or CT? Inner bowel, outer bowel. So inner circle, outer circle. What is that sign called as? Target sign or donut sign. Okay, that is called as target sign or donut sign. So this is intersusception. Okay, claw sign, intersusception. Right? Next one. What is answer to this one? Deterministic effect of radiation. That A, B, C or D. I hope you remember the radiation wale side effects mein. There is deterministic versus there is stochastic side effects. Deterministic versus stochastic hazards. In deterministic hazards, we have seen that deterministic is where you can determine the threshold, right? It will not occur below that threshold. Stochastic, CHA, is by chance, right? Stochastic is by chance. It will occur or it will not occur, right? That means there is yes or no phenomenon. There is no severity here. It's a yes or no. So that means it's a probability. Okay, while here it is severity. As you increase the dose, the severity increases. Okay, example of stochastic CHA is CA, radiation-induced cancer, radiation-induced mutations. All of these are stochastic. Okay, rest everything, radiation-induced skin erythema, cataract, alopecia, bone marrow suppression, all of those are deterministic. Okay, so deterministic, determine the threshold, there is a threshold. Okay, so this is out, this is out. Severity varies with dose or probability. It is severity. So the answer is going to be A. Is this clear with everyone? Probability varies with the dose, but there is no threshold. This is going to be your stochastic effect. Okay, this is going to be stochastic effect. Okay, important. Please remember this. Next one. What is the diagnosis here? See, whenever you are not able to identify the image, you don't have to do that in the exam. You have 4 options. You just have to see कि sinusitis है क्या, तो sinuses कैसे दिख रहे हैं, osteoblastic metastasis है, osteoma है, depressed skull fracture है. So if you see, there is some white area here in the right frontal sinus that you are seeing. So that white is like the bone, the ivory bone, that is osteoma. Okay, so this is going to be osteoma. So look at this one. This is the CT. This is the white area representing that osteoma. Okay, that is osteoma. What is this one here? Is this osteoma? Is this appearing white, dense white? No, this is not osteoma. What is this? The frontal sinus का एक यहाँ पे expanded area है. The bone is thinned out. So expansion of the frontal sinus with the thinning of the bone with not white area. What is this? This is the frontal mucocele. Okay. This is the frontal mucocele. Mucus, because it is a dense fluid. It can appear like not absolutely gray, but still denser than that, more white than that. So that is going to be frontal mucocele. This is not Pott's puffy tumor. See, what you will see in Pott's puffy tumor is the osteomyelitis. So the bone is going to be very irregular there. Okay, so with surrounding abscess. Here, you are not seeing the irregularity of the bone. Okay, so that's why this is not POTS puffy. So similarly, this is MRI in this patient where you can see this white. White is not the calcification. This is T2 may white appearing. This is T2 white fluid containing sinus, expanded sinus. This is the mucocele. Has been asked in one of the NEET PG exam. So mucocele can occur post trauma. Remember, frontal mucocele can compress on the orbit and cause proptosis, right? So that is what the history was given, history of trauma with proptosis, and this mucocele was given. Okay? There's no fracture here. So this is not a leptomeningeal cyst. Okay, there's no history of trauma with a growing scalp mass. You can see, if you are thinking कि यहाँ से ये बाहर आ रहा है, but this is the area of the sinus. You can see the sinus is expanded. Mucocele, seal मतलब expansion, and with mucus, so that is mucocele. Okay, right? Going to next one. What imaging finding will support the diagnosis of SCFE, slipped capital femoral epiphysis? That is going to be disruption of Kleene line. This is your one of the PYQs of FMGE exam as well. So remember, disruption of Kleene line. The rest of the three options fit into the diagnosis of fragmentation of femoral epiphysis, radiolucent subchondral fracture, sclerosis of the femoral head. All of this fit into the diagnosis of, yes, that is like AVN, avascular necrosis of femur. DDH में क्या होगा प्रदीप? DDH मतलब just that the femoral head is dislocated, right? Nothing is happening, like there's no fracture or sclerosis which is happening. This fits into avascular necrosis, that is Perthes disease. Okay, very good. Correct. That is Perthes. Correct. Okay. And Kleene line is something which helps you in the diagnosis of SCFE. What is the positive sign called as? If positive, that is called as Trethowan sign. Okay, if positive, that is called as Trethowan sign. So look at this. You can get an image-based question as well. What line is shown here? Is it Shenton's line, Kleene's line? This is the Kleene's line. Lateral aspect of neck, you pass a line tangential to it. It should go through the femoral head epiphysis. If it is not going through, it is just touching or not even touching, it is not going through it, it is just touching, then that means that the femoral head has slipped. Okay? Look at this image. The line is going through the femoral head. Here the line is not going through the femoral head. That is SCFE. Okay, that is SCFE. Clear with everyone? Right? Next one. Newborn with respiratory difficulty. This is the chest X-ray shown. So what is the most likely diagnosis? This is congenital lobar emphysema, where you can see this part is appearing more lucent, more dark. It is pushing the mediastinum to the opposite side. So this is appearing more hyper expanded dark area, pushing the mediastinum to the opposite side. This is congenital lobar emphysema. Congenital venolobar syndrome. This is also called as Scimitar syndrome या PAPVC जो होता है. What do you see here is Scimitar sign. Okay. The venolobar syndrome has this abnormal pulmonary vein draining into the systemic circulation rather than going into the left atrium. Okay, so this is the pulmonary vein which will drain into the systemic circulation. This is called as Scimitar sign. Okay, that is called as sword-like appearance, Scimitar sign. One lung, that lung appears smaller as compared to the other lung. So, congenital venolobar syndrome. And what are you seeing here is, this is the aortic arch. Rather than seeing on the left side, you are seeing it going on the right side. Okay, so this is the right-sided aortic arch, commonly associated with tetralogy of Fallot. Okay, this is a right-sided aortic arch is commonly seen in tetralogy of Fallot. Okay, next one. See, whenever you have lengthy question, no, the first thing that you should do is read the last line. So the last line is telling you that what would favor a diagnosis of Wilms over neuroblastoma. So the crux of the question is already given there. You don't have to read the entire question and waste your time there. What would favor Wilms rather than neuroblastoma? It's going to be lung metastasis. In Wilms, remember, this is the most common distant metastasis site in Wilms is lungs. Okay. Calcification is neuroblastoma. Bone metastasis, neuroblastoma. Encasement of vessels is neuroblastoma. So if you look at our notes, radiology notes, we have discussed this in our main video. The difference between Wilms and neuroblastoma. You can see this calcification in neuroblastoma, right? It is encasing the vessel. Okay. So vascular encasement, calcification, bone metastasis, crosses the midline. All this is neuroblastoma. Pulmonary metastasis is Wilms. Wilms causes vascular displacement rather than causing the encasement. Remember, encasement, EN, is seen in NCC. That is neuroblastoma. So NCC का calcification भी याद रखना. Crosses the midline, calcification. All this is neuroblastoma. So encasement, calcification, crossing the midline, this is going to be neuroblastoma. Okay. So remember, lung metastasis is Wilms. Bone metastasis is neuroblastoma. Okay. Next one. LINAC provides radiotherapy by. What does LINAC stand for? Linear accelerator. Okay. So LINAC produces X-rays and electrons. We have discussed this in radiotherapy. So what is it using? It is using X-rays. Okay, it is using X-rays. LINAC is X-rays and electrons, right? Next one. What could be the possible diagnosis here? What are you appreciating on the CD brain in this image? What are you seeing in the CT brain? Can you appreciate these white dot areas? What does the white represent? The calcification, right? This is the calcification that you see with neurocysticercosis, the last stage. Okay, so this is neurocysticercosis. Okay, these are neurocysticercosis scattered in the brain that you are seeing. What is this appearance called as? Starry sky appearance. Okay, this appearance is called as starry sky appearance, neurocysticercosis. Is this clear with everyone? Do you see calcifications in tuberous sclerosis? Do you see calcifications in tuberous sclerosis? Yes, but where are those calcifications? You do see calcifications in tuberous sclerosis, but where? Those are the calcified. Classical location is subependymal nodules. Okay, calcified subependymal nodules. Absolutely right. Okay, so you will see the calcifications here along the ventricle ka margin. Ependyma is a ventricle. So you will see the calcifications along the ependyma. Doesn't it have a dot in between? See, neurocysticercosis has various stages. Vesicular stage, colloidal stage. तो उसमें जब होता है, then you see a cyst with a dot. Okay, in that case, you see a cyst with a dot when it is the early stage. In the late stage, what happens is this scolex, which is there in that cyst, that parasite, that scolex becomes dead. You just see that scolex as the calcified dot. That's it. Okay. See, hemorrhages versus calcification. Both of them appear white on CT. Compare it with the bone. Hemorrhage is not going to be as white as the bone, right? Calcification will be as white as the bone. Okay. Is this clear with everyone? Yes. Bleed also appears white. Calcification also appears white. Calcification appears white like the bone, and hemorrhage will be slightly lesser than the bone. Okay. And what is this type of calcification called as, and where do you see this? This is called as rice grain calcification, and this is the muscle wala cysticercosis, right? The cysticercosis occurring in the muscle. So this is the rice grain calcification. Again, this is cysticercosis. Cellulose, right? बाकी जगह होता है तो cellulose term use करते हैं. So this is rice grain calcification. You will see them along the muscle fibers. These are the calcifications. Okay. Next one. What classical sign is shown here? And in which condition do you see this sign? This is also one of the NEET PG PYQs, right? Similar image was asked. Correct. This is the double density sign. If you look at the sinus very carefully, can you appreciate कि इसमें white areas है और उसके आजू बाजू gray areas भी है. So there are two densities that you are seeing, the white area and the gray area, right? So there is white area and the gray area. So this is going to be double density sign. And where do you see this double density sign? Which condition? This is seen in allergic fungal sinusitis. Okay, this is seen in allergic fungal sinusitis. So allergic fungal sinusitis, it has the fungal components as well, appearing dense, appearing white, and it has the allergic, the mucus as well, which is appearing gray, right? So remember the fungal elements with the mucus, that gives the double density sign. Where do you see onion peel appearance bone mein? Onion peel, that is Ewing sarcoma. In which bone condition do you see ground glass appearance? Ground glass appearance of the bone is seen in fibrous dysplasia. Fibrous dysplasia. Honeycomb appearance in the CD chest is seen in UIP pattern. UIP or IPF pattern of interstitial lung disease, usual interstitial pneumonia, idiopathic pulmonary fibrosis, you see the honeycomb pattern. Okay, clear with everyone? Yes. Going to next one. What is the diagnosis in this case? There is bone pain, abdominal cramps, abnormal behavior, and what will be? So all these put together, what condition are you thinking of? See, whenever you have one of these options, which is SYSTA-MEB scan, it should ring the bell key. Is it fitting into hyperparathyroidism? This is hyperparathyroidism ke features. Groans, bones, moans, stones. Remember? There's hypercalcemia, there are stones, right? Groans, moans, psychiatric features, abdominal pain, bone pain. So this is hyperparathyroidism, right? SYSTA-MEB scan is what is done for hyperparathyroidism. Never to be forgotten. Very, very important. SYSTA-MEB scan for hyperparathyroidism. Okay. Next one. What is the most probable diagnosis here? Start ruling out the options. Pneumothorax. Which side pneumothorax? Right side or left side? Very good. Pneumothorax is air in the pleural cavity. Air appears black. So you will see pneumothorax as the black area. Clear black area without any vascular markings. It is appearing just black without any vascular markings. If you look at the normal lung, you can appreciate these white vascular markings. So this is the normal lung, while this is the pneumothorax, air outside the lung. Where is the lung here? This margin that you are seeing here, basically this is the collapsed lung that you are seeing. Okay, the white collapsed lung, and this is the pneumothorax surrounding that. You can appreciate this visceral pleural line, and this entire thing is the pneumothorax. One of you said it's pleural effusion. Remember, pleural effusion is water. On X-ray, it appears white. First thing you see is blunting of costophrenic angle that you are not seeing here. You are not seeing the white fluid. So this is not your pleural effusion. Why this is not hydropneumothorax? It has air fluid level. Hydro and pneumo, water and air. So air fluid level is what you would see in hydropneumothorax. Okay, clear with everyone? Okay. Thank you so much, and I'll see you again soon. Till then, goodbye and take care.